Good evening, delegates and participants. Thank you for joining Shieldconnect. And today we are back with the webinar with a well-renowned doctor from Mumbai, from Opera House, Dr. Reshma R. Rao. We welcome ma'am on our platform for today's webinar. And ma'am is going to take a topic CA ovary. And let me give a brief introduction of ma'am. Dr. Reshma R. Rao has done MD, DGO. Ma'am is consultant gynecologist attached with various big hospitals, Safi Hospital, Bharti Hospital, HN Reliance Hospital, Elizabeth Hospital, and Ruxmani Hospital. And the field of interest of ma'am is high-risk obstetrics, endoscopy, and vaginal surgery. So, ma'am, we welcome you on our platform for today's webinar. And I hand over the session to you, ma'am.
Hello, good evening to all of you. So today I'll be discussing about CA ovary. It's not exactly my field. As you know, the CA carcinoma cases are basically an oncologist field, but I will try to give you the best which I can with my experience. Now, carcinoma ovary is when we see in an overview, it can be an epithelial ovarian cancer. It can arise also due to the fallopian tube, or we can have a primary peritoneal carcinomatosis. This is a diagrammatic representation of the uterus and the adnexia. And we see that the ovarian cancer is not a single entity, but it can represent tumors of epithelial origin, germ cell origin, or sex cord stromal origin. Now, coming to the incidence of CA ovary or the epidemiology, we find that carcinoma ovary per 100,000 people in India compares a little less as compared to the United Kingdom, where it's 11.7 per 100,000. In the United States of America, it is about 8 per 100,000. In India, it was diagnosed around 4.9 per 100,000. It may be that some of the cases in the rural areas are not diagnosed well. In coming to the comparison between the different carcinomas which are seen in the women, that is the breast, cervix, uterus, and ovaries, in the Indian Cancer Registry, we find that breast is the commonest, and this is up to 31%, and cervix is after that, and ovary is comparatively less, only 7.1. In the rural areas, we find it is even lesser, only 3.5. So 10 relative proportions of leading sites of cancer, we find its breast is the maximum, 20.3%, cervix is 15.4%, and ovary only 7%. This is probably, like I mentioned, diagnosis of CA ovary is difficult and is often missed. We find that the 5-year survival rate of carcinoma ovary is around 46%. So I'll be going into this in further details. Now, coming to the survival stage by stage of the ovarian cancer, we find that very few percentage are diagnosed in the early stage, localized, that is the cases which are 1 or early 2. Only 15% are found diagnosed in the early stage. Those which have spread to regional lymph nodes, that becomes stage 2 or so, or 3, this becomes 19%. And those that have distant metastasis, that is, it has metastasized all over their abdomen and even to the inguinal nodes, lungs, etc., this is 60%. So a large number of cases, we find that the cancer is diagnosed after it has reached 3 and 4 stage. This accounts for the poor survival rates also. So we find that when it is diagnosed in the early stages, you get up to 92% 5-year survival rate. And when it is localized to the pelvis, you may get 73% 5-year survival rate. In distant cases, only 24 to 28% 5-year survival rate is there. The pattern of spread of carcinoma of the ovary is by direct exfoliation of cells into the peritoneal cavity. It travels along the peritoneal fluid, goes to the paracolic gutters, and goes to the mesentery of the bowel, goes further to the hemidiaphragm, to the undersurface of the liver, intestines, omentum. Rarely it can even invade the lumen of the bowel. Direct extension is also said by contiguity, and lymphatic spread is also there, 20% going to the pelvic and paraaortic nodes. Hematogenous spread is there. It can go to the lungs and liver, the bone and brain. Symptoms: a large number of patients of CA ovary may be asymptomatic in the initial stages. In the initial stages, because of the no symptoms, they are often the diagnosis is missed. When it is advanced, then one of the commonest symptoms is bloating in the abdomen and a feeling of early satiety. The signs on checkup are, you find a pelvic mass, which may be palpable if large per abdomen or on per vaginal examination. Occasionally, you get distension due to ascites, and in advanced stage, pleural effusion. How do we proceed? So first of all, when you see a case which is highly suspicious of malignancy, first of all, you should get a sonography, abdomen and pelvis with a color Doppler. And in that case, you get a consultant's opinion. And then you will find three different situations. You may find an adnexal mass with ascites. You may get an adnexal mass without ascites, or you may get both adnexal mass as well as ascites. So how do we manage further? So if you get an adnexal mass without ascites, you will do complete physical examination. You will do a detailed family history. You take a detailed family history, check for history of breast cancer and ovarian cancer in the family. The tumor markers based on clinical judgment, that is the CA125, alpha-fetoprotein, beta-HCG, LDH, CEA, and CA99. Ultrasound is the mainstay of diagnosis, transvaginal ultrasound. And in ultrasound, there are certain parameters which give us the risk of malignancy, which we will be going to later. The complete blood count, liver function, kidney function, chest X-ray, then calculate the risk of malignancy. Then it is mentioned here that you can take a biopsy or an FNAC, but when it is without ascites, and if you take a percutaneous needle aspiration, it is not really advisable because you can upstage a cancer, and a cancer which by chance may be just stage 1 may become stage 1C. So it is not advisable to do a percutaneous FNAC. Open biopsy can be done, but needle aspiration is not advisable. Then in the ones with ascites, you again do a complete, in adnexal mass with ascites, you do a complete examination. Again, you go for the sonography, risk of malignancy. Tumor markers also have to be repeated, and chest X-ray, and you can do capping of the pleural effusion if it is detected. If you have fluid, then very carefully the fluid paracentesis may be allowed, and that may not be dangerous. And this you can check for malignant cells, and you can repeat it if required. And if there is ascites without an adnexal mass, then you can evaluate the ascites as per protocol. If the TAP is positive for malignant cells, then you do the immunohistochemistry to check whether it is connected with the ovary or it is connected with the GI tract. Consider endoscopy, especially if GI-related symptoms are there, like occult blood in stools, elevated CEA levels. Then check for the CEA, CA125 levels. Check whether the tumors are bilateral. Then you have to decide about the further plan of management. Now, what are the details about CA125? CA125 is a glycoprotein which is produced by the epithelial ovarian cancer cells, but it is also produced by pleura, pericardium, peritoneum. It is also elevated in a large number of other conditions. The normal level is up to 35. Up to 200, you may find it in benign conditions like endometriosis, adenomyosis. But more than 200, benign disease is unlikely, though it cannot be guaranteed. At times, in severe endometriosis, you may find CA125 raised more than 200 also. This is elevated in only 28% of non-gynecological malignancies, but in epithelial cancer, it is raised in 82%. So coming to the other cases in which CA125 is raised, you find it is raised in endometriosis, acute PID, adenomyosis, functional cysts, ovarian fibroma, uterine fibroids, ovarian carcinoma. Of course, it is raised, that we all know, but it's also raised in endometrial carcinoma, other conditions like acute hepatitis, pancreatitis, chronic liver disease, SLE, and also in carcinoma of the pancreas and carcinoma of the breast. So it is a very, very non-specific thing, not a reliable diagnostic test. So if you find a postmenopausal woman and she has an adnexal mass, and the CA125 is more than 200, this is definitely a good sign for highly suspicious for malignancy. This is also useful to remember that in the immediate post-op period, the CA125 is elevated due to peritoneal inflammation, and may not necessarily indicate recurrence so fast. Declining treatment, also declining level of CA125 correlates with the response. Sometimes you can get disease progression without the increase in the level of CA125. Then sometimes after 3 cycles of chemotherapy, it lacks predictive power. And after treatment, if there is a persistent elevation, it indicates a poor prognosis. If there's a doubling of the CA125, it can predict a relapse. Negative values do not exclude disease. And sometimes the CA125 is raised, and this can precede clinical and radiological evidence. We find that sonography is more sensitive in detecting ovarian tumors as compared to CT. You check the nature of the cyst. If there's a complex cyst containing solid and cystic components, and sometimes with septations and internal lipogenicity, this is highly suggestive compared to a simple cyst. A simple cyst is more in favor of a non-malignant. Then you also have to correlate the signs and symptoms and check the raised tumor markers. Then if there is strong suspicion of malignancy, then you have to further evaluate. The color Doppler is also important and gives very important information, as we'll be going in for, as we'll be explaining later. You avoid percutaneous biopsy, as I mentioned earlier. This may lead to cyst rupture and spillage of cells into the malignant, into the peritoneal cavity, leading to upstaging of the disease. And in a simple cyst, which is not having any sonographic features of malignancy, and normal CA125, and the size of the cyst is small in a premenopausal women, may not always require surgical management. Color Doppler is extremely important in helping us in diagnosing malignant or suspecting a malignant ovarian cyst. This evaluates blood flow to an ovarian mass and can potentially identify malignant on the basis of abnormal neovascularization. In premenopausal women, simple cyst may be functional, or benign cystadenoma, which may resolve spontaneously. If you find a simple, in a postmenopausal women, however, if you find a simple cyst also, but there's a raised CA125 of CA, and the cyst is 5 to 10 centimeters in diameter, and there is abnormal color Doppler flow, you have to do a surgical evaluation. A complex cyst also, you require surgical evaluation. If there's raised CA125 and cyst of more than 5 to 10, you have to go for surgical evaluation. CT may help in defining the extent of peritoneal disease. You may look for lymph nodes, you may look for metastasis in the liver, and may help in surgical planning by locating site of suspected bowel obstruction. However, it does not give us detailing for helping us find out, for indicating the nature of the cyst and signs of malignancy, as is given by a good sonography and by MRI. CT chest to evaluate pleural effusion, which occurs in 10% of patients. MRI does not have much advantage over CT except in pregnant women. PET CT is also not particularly good. It may be used in follow-up. The risk of malignancy index, there are some complicated scoring systems, but you have to remember the main principles I mentioned, that is sonographic features of multilocular, presence of solid areas, the presence of ascites, presence of medicines intra-abdominal, and CA125 level. All these things are taken together, and a scoring system is performed. And this score, if it is high, more than 200, indicates malignancy. This can be used for surgical planning. However, in practice, we do not really do a scoring. We use our this thing and see all the different features, and then generally decide. Now, what happens when you have done all the tests, and how do you further manage the case? Then if you have seen the case and you decide on examination that the mass is operable, then you have to go ahead for surgery. Now, if the consultant sees on the basis of all the investigation, decides that it is inoperable, then you may have to plan differently. However, surgery has to be done to confirm the diagnosis, and usually in the surgery, you must have a histopathological diagnosis, and then further manage the case. We'll be coming into the details of the surgery. The first surgery in the case of stage 1 and stage 2, it should be correctly. You should diagnose the case, do a frozen section if required, confirm the diagnosis, and if it is operable, the operation should be done complete so as to leave minimal amount of tissue. And then you have to assess by June chemotherapy to be given later. If you open the case and find it to be inoperable, that is, it is too extensive to be completely removed. Then we take a biopsy from multiple sites, take the fluid for checking, take everything that you require to stage the disease. And then when you close the case, await the reports. And then after the reports, you can start neoadjuvant chemotherapy. That is, the chemotherapy is given for 3 cycles. And then further later on, after 3 cycles, you can assess whether the case is suitable for surgery. So what are the criteria for inoperability? The medical inoperability, that is a poor general condition, and multiple comorbidities. That is if you find that she has severe diabetes, severe hypertension, heart problems, and may be unfit for surgery. But surgical inoperability also may be there. Stage 3 with deposits more than 3 centimeters, and stage 4, and technical inoperability. Surgical exploration is done by exploratory laparotomy. Now, a transabdominal hysterectomy and bilateral salpingo-oophorectomy. This serves the exploratory laparotomy serves 3 purposes. It determines the extent of disease. So when you open with a midline incision, going right up to the umbilicus and even above the level of the umbilicus, you inspect the ovary, the adnexa, and everything. Look for the spread. At the same time, examine the omentum. Look for any spread over there. Examine the liver, and at that time, a clinical staging is done. If it is operable, then you remove the tumor and send it for frozen and go ahead with hysterectomy. This gives you a histological confirmation. The goal of the surgery, if you plan to do surgery, is to resect margins or do optimal cytoreduction debulking. So optimal cytoreduction is defined as having less than 1 centimeter diameter residual tumor. This gives a better prognosis for future survival rate as compared to when you leave greater amount of residual tumor. So as mentioned here, the incision should be large enough to permit inspection of the peritoneal cavity, the upper abdomen, retroperitoneal spaces. The fluid should be collected from, if there's ascitic fluid, you collect from the pelvic spaces, from the paracolith, and send for cytological examination. If intraperitoneal carcinomatosis is absent, then first resect ovarian tumor and then go to surgical staging to avoid rupturing the mass. And even if for some reason you do a conservative surgery, you should take a biopsy of the other ovary. Pelvic and paraortic retroperitoneal node, if no, should be removed. And if you find, if you've got the report and it has confirmed malignancy, then intracolic omentectomy is done if the gross disease is not present in omentum. If omentum is severely involved, it should be completely excised. Carefully examine the right hemidiaphragm, liver serosa, liver parenchyma. Then spleen is carefully examined, as well as the left diaphragm. If the tumor appears to invade large bowel, you may require to do an incisional resection. And also the small intestine and mesentery are evaluated. In very, very small percentage of cases, in younger women who wish to preserve fertility staging, and in a case where you are sure that the stage is only stage 1A grade 1. So Desire and co-workers, they outline criteria for preserving childbearing function in a young woman with stage 1A grade 1 epithelial ovarian carcinoma. Also, you can do it in borderline carcinoma. So then you have to have these following criteria to be satisfied. That is, the tumor is confined to 1 ovary. The tumor is well differentiated grade 1 with no invasion of capsule lymphatics or mesovarium. The peritoneal washings are negative, lymph nodes negative, and omental biopsy is negative. And young women who wishes to preserve reproductive function, then you can only do the oophorectomy in this case, and follow up the patient, and then check further annually so that there is no further progress. Now, just coming to the staging, which is effective from 2014. There was initial staging which has been slightly revised. We find that the revision is mainly in 1C. So what are this staging? 1A is a tumor which is limited to 1 ovary. The capsule is intact, no malignancy on the surface and negative washings. 1B is similar, but in both ovaries. Again, we find the capsule intact, negative washing. 1C is tumor limited to both ovaries, but there is either surgical spill. Surgical spill may occur during the time of laparotomy, that at time of delivering of the tumor, you may just spill it, which should not happen, or some wrong decision has been made and you may do a needle puncture to check the malignancy percutaneous. It should not be done because you upstage the disease from 1A to 1C. So surgical spill is something which happens by the surgeon. Then 1C2 is rupture of the capsule before surgery, or you find tumor on the ovarian surface as soon as you open. So it is spontaneous rupture of a large cyst, or as soon as you open, you find tumor outside. It is ovarian. It is 1C2. And C3 is the cyst looks normal, but malignant cells with ascites or peritoneal washings. Stage 2 involves one or both ovaries with extension into the pelvis below the pelvic brim. In this, the new classification says that extension or implant into the uterus and fallopian tubes is 2A, and B is to the other pelvic intraperitoneal structures, that is surrounding bowel, etc., may be also involved. Then stage 3 is tumor involves one or both ovaries with spread to the peritoneum outside the pelvis and or metastasis to retroperitoneal nodes. So 3A is further has been divided into 3A1, that is positive nodes only, and when this is less than 10 mm, it is 3A111, and 3A12 is when metastasis is more than 10 mm. 3A2 is microscopic extrapelvic peritoneal involvement. That is all this, the peritoneum above the pelvic brim is involved with peritoneal lymph nodes, positive, may or may not be positive. 3B is more than 2 centimeters metastasis, which is extrapelvic with or without lymph nodes, includes extension to liver or spleen. 3C is peritoneal metastasis more than 2 centimeters. 3B is less than 2 centimeters, and 3C is more than 2 centimeters. Also includes extension to capsule of liver and spleen. 4 is the most advanced stage, and this is 4A with pleural effusion, and this is 4B is hepatic parenchymal metastasis and metastasis to extra-abdominal organs, including inguinal nodes and other nodes. Other major recommendations are: do the histological type, including grading, should be designated at time of staging to give the full picture. And the primary site, ovary, fallopian tube, or peritoneum should be designated. And if there are dense adhesions, and if the adhesions have malignant cells, then they go to the upstage of stage 2. Histopathological confirmation is also very important. The World Health Organization histological classification for ovarian tumors separates ovarian neoplasms according to the most probable tissue of origin, that is surface epithelial with the commons, germ cell 15%, sex cord stromal 10%, and other miscellaneous. So we have serous tumors which can be benign, malignant, or borderline. Mucinous also, which can be benign, malignant, or borderline. Endometrioid, which are the same, benign, malignant, or borderline. Clear cell tumors, which may also be the same. Transitional, which are the Brenner's tumors. Here also we get the benign, malignant, and borderline, and you get other non-Brenner type of transitional also. Then adenosarcoma and carcinosarcoma, mixed Mullerian tumors. An evolution of chemotherapy in CA ovary, we found that because a large number of cases of CA ovary are diagnosed late, so chemotherapy after surgery is almost always required. We started off in 1960s with 70s when cyclophosphamide and alkeran and some radiotherapy was given. In 1977, it was found that at that time that cisplatin and doxorubicin gave better results. They moved on to cisplatin and cyclophosphamide. Later on, carboplatin and cyclophosphamide were used, and carboplatin and taxane were used. From 2010, we find that carboplatin and liposomal doxorubicin are used. So the type of chemotherapy, combination chemotherapies in individual keeps on evolving, and with greater research, we find that better and better molecules which give better results and lesser side effects are evolved. So in the pre-1970s, single agents such as methylan, chlorambucil, and cyclophosphamide were used. The 5-year survival for advanced disease was only 7%. And in 1978, the combination chemotherapy was used of cyclophosphamide, methotrexate, and 5-FU. This extended the survival by more than 12 months over single drug therapy. However, it caused significant more side effects. Then later, cisplatin was approved for ovarian cancer, and combination regime of cyclophosphamide plus cisplatin was used. In 1989, carboplatin became available as second line of therapy. Later, it became the preferred initial therapy after it was shown to be as effective as cisplatin with fewer side effects. 1992-94, taxanes emerged as vital chemotherapy, and in 1996, topotecan was approved. In 1999, liposomal doxorubicin was approved, and so hence we find that more and more newer drugs are introduced. In 2006, intraperitoneal chemotherapy was introduced. The overall survival rate, however, as I mentioned earlier, it remains low. But compared to the 60s, 80s, and 90s, we find that there is a slight improvement in the 90s, in the 90s, as compared to the green line over here, shows a slightly improvement in the survival rate. But as we see, it is not a drastic improvement in the 5-year survival rate. It's just slightly increased, say, from about 20% to 30% with all the new drugs. And beyond that, the 5-year survival rate is very, very low. Now, so this binds to this thing. Coming to this, carboplatin is a second generation platinum analog. This is less nephrotoxic, neurotoxic. However, it is rapidly excreted by the kidney. However, it is a dose-limiting toxicity, and it has to be given in small doses because of the toxic effect on the bowel. Now, so liposomal doxorubicin, it inhibits this topoisomerase 2. It is decreased uptake in normal tissues. However, the toxicity is myelosuppression, cardiotoxic also. Now, coming to early stage ovarian cancer, we find that initially 3 cycles of chemotherapy were given, but it was found later on that when studies were done, it was found that 6 cycles gave much better results. So therefore, 6 cycles is considered reasonable even in early stage high risk high risk cases. The dose regime is mentioned here. This is a little complicated, and this is the ones who are giving it on day-to-day basis. They are used to it, but there are certain formulas and they have to be followed. Now, what about the role of radiotherapy? Ovarian cancer has a unique pattern of dissemination compared with other tumors. Transperitoneal spread is the most common route, and techniques that encompass the whole peritoneal cavity rather than the pelvis or lower abdomen are likely to be beneficial. So this Princess Margaret Hospital, they did a study and they found that abdominopelvic radiation was superior to pelvic radiation or with respect to long-term survival. This benefit applies only to patients with small or no macroscopic tumor remaining. So this is the radiation, how you use it with a portal. The whole abdomen is given and you give a little boost to the abdomen. The moving strip is also one of the techniques which was used earlier, not so much now. However, so we find that radiation was given now, not so much. The dose of radiation that can be limited safely to this large volume, including the upper abdomen, is low because of the side effect on the bowel. So then the amount which is needed to eradicate solid tumors is not really possible. Radiotherapy would benefit only patients in whom the volume of residual tumor post-op in the upper abdomen is less, that is, it's only microscopic. So this is a 10-year experience, and they have said that in radiotherapy, they said the dose to the abdomen should be that which can tolerate by the liver, and you found that radiation was of limited value only in cases of ovarian screening. So how do you integrate this? They can integrate radiation therapy in the management. So we find that in spite of this treatment with cisplatin, when there's a recurrence, then at times you have to treat them with radiation. Intraperitoneal radioactive phosphorus therapy in ovarian carcinoma can also be used, and this also was used. However, this has its own complications. So, in locally advanced cases, in these cases, the primary surgery, you should do a debulking therapy remove large necrotic tumors with blood supply that may lead to impaired chemotherapy, and leave the minimum amount of residual tumor. This may be the primary debulking surgery or interval debulking surgery. So prior to chemotherapy, if you do the primary debulking, this is the standard approach. This is not possible in some patients due to extensive bulky intra-abdominal diseases. So you may have to do chemotherapy followed by an interval surgery approach. Interval debulking surgery is when you administer neoadjuvant chemotherapy followed by surgery. The theoretical advantage of neoadjuvant chemotherapy includes rapid improvement in quality of life, technically later on more feasible operation with shorter stay, and confirmation of the ovary primary, however, is mandatory. So it was found that stage 3 and 4 cases, stage 3C and 4, neoadjuvant chemotherapy gives a better result than primary surgery in these cases. Hence, it was concluded in this study that stage 3 and large metastatic tumors have higher survival with neoadjuvant chemotherapy. Advanced stage is chemoresponsive, but you must have a histopathological diagnosis before giving the chemotherapy. Relapse eventually does occur. Platinum-based compounds remain the single most active drugs. Carboplatin has similar advantage as cisplatin with less survival advantage, but less neuropathy, nephropathy, and emesis. Intraperitoneal chemotherapy. In this, the ovarian cancer is largely confined to the peritoneal space. This is useful when the ovarian cancer is largely confined to the peritoneal space. It permits a several-fold increase in drug concentration within the abdominal cavity, and the efforts are made to instill chemotherapy into the penile cavity. It may be possible to achieve cytoreduction, but this method had its own side effects of like as mentioned here, complications such as obstruction, inadequate distribution, infective peritonitis, and bowel perforation. So hence, this has not gained a universal acceptance. So coming to the cases, just an overall management condition. How do we assess the response? First of all, if you find in the initial situation that the case is operable, that is stage 1, or maybe at the most early stage 2, then you do a complete operation surgery, and then you do a total hysterectomy, remove all the things, all the fluid in the gutters, and then the fluid is checked. You do a complete checking of the whole abdomen for staging, you wait for the pathological response, and then you decide and you give adjuvant chemotherapy, maybe 3 or 4, but even if required, even 6 cycles. And in this thing, if it's inoperable, then you take a biopsy, get all the fluid, get a good grading and staging, everything done properly, and then you give neoadjuvant chemotherapy. And then later on, after a few cycles, 3 to 4 cycles, you may do interval cytoreduction if possible, and then further chemotherapy of the 6 cycles. Further surgery for reassess may be required if there is recurrence. It depends on the surgeon who is managing the case. Inoperable, if you do not get adequate response with chemotherapy, only minimal response, then you have to manage the case. Debulking may be done. Try whatever chemotherapy is possible, or palliative radiotherapy is done. Various drugs like tamoxifen, etc., which are not known to give results, sometimes may be tried for whatever benefit they can give. Now, what is maintenance therapy? So, the maintenance therapy is some continuous therapy which is sort of maintained in patients with with a higher stage, with 3 or 4, to increase the progression-free survival and subsequently the overall survival and the quality of life. The medicines which have been tried include single agent paclitaxel monthly, or maintenance bevacizumab. So these things, when they are given, we found that the progression-free survival was improved and the quality of life was improved. So this is maintenance therapy. This is carried out by some people who believe in this method. So how do you follow up the case, or how do you manage recurrences when they occur? You assess them through the early assessment of recurrence, monitor the response to therapy, do a radiological assessment, do the CA-125, and if there are symptoms like abdominal pain, heaviness, distension, per abdomen, if there is a nodule, if there is a reappearance of that, then you do a sonography, do a PET CT, check for any recurrence, and you may require to give additional treatment. Now, CA-125 is also used, and how is that used for the monitoring of the patient? After treatment completion, if level is normal, then you repeat it then you repeat it every month for 4 to 6 months. And if it is elevated, it shows a poor prognosis. However, it is not a definitive value, and normal values do not exclude disease absence. You must, along with the CA-125, do a clinical checkup. If the elevation sometimes may precede clinical or radiologic evidence of recurrence. So if you find a raised CA-125, you follow up monthly. You do a PET CT if available. If there's sudden doubling of the CA-125, you do a 2-monthly CT scan and look for any recurrence of the disease. In asymptomatic and clinically non-palpable disease, you can do a ultrasound and a CT to check for the follow-up. You follow up with CA-125, PET CT is available, and sudden doubling of CA-125, you may have to consider recurrent disease. Most patients with carcinoma, which are except the very rare stage 1, in which we can accept cure, most of the patients will recur after the first-line chemotherapy. Relapse can be either biochemical or with clinical radiological features. So, depending on the interval of relapse, if it is progressed right during the chemotherapy, during the platinum chemotherapy, it is called platinum refractory relapse. That means they are refractory to the treatment given. If it is less than 6 months after the treatment is complete, it is platinum resistant relapse. And if it is more than 6 months, then it is platinum sensitive relapse. That means they have allowed the patient to have some quality of life for some time, and the patient has relapsed later. So then accordingly, when we find the relapse occurs, then you have to further plan further chemotherapy depending upon the clinical checkup and the CA-125 and the radiological features. The aims of treating is that you must control the disease as far as possible, maintain the quality of life, and extend survival. You have to consider the balance between efficacy and toxicity. This is the main key skill for ovarian cancer management. The second line interval, when there's a platinum-free interval, you can repeat the some type of carboplatin type of treatment. Then it also depends upon the histological subtype and the BRCA type status. It depends on the patient and physician preference, and depend on the general condition of the patient and the toxicity that the patient has felt in the previous studies. Hormonal therapies are just mentioned, but they are not really useful. And as we know that in endometrial CAs and other such CAs, hormonal therapy is used, but here there is no real role of hormonal therapy. The agents, hormonal therapies that are used are progestational agents, anti-androgens, tamoxifen. So this is for recurrences where the patient cannot tolerate chemotherapy and there is no other scope of giving anything else. Then for whatever benefit is there, you can give tamoxifen 20 milligrams daily or medroxyprogesterone 100 milligrams to 200 milligrams per day. The benefit is really minimal. If the platinum-free interval is less than 6 months, that means that they are less likely to respond to platinum-based chemotherapy. Then you can treat with some other agent like liposomal doxorubicin, paclitaxel, Taxol, or docetaxel. The second-line chemotherapy in patients with platinum-free interval between 6 and 24 months, you may use some other therapy. Platinum versus other chemotherapy. These patients have found that in patients who are responding to platinum, it is worthwhile. In the platinum-sensitive ones, it is better to use platinum again to get a survival rate. So it was found that in platinum-sensitive relapsing ovarian tumors, the combination of platinum carboplatin was not inferior in the platinum-free survival to paclitaxel and carboplatin. So it was found that both these combinations were equally effective regimes for these patients. So in recurrent ovarian cancer, you first of all see whether they are platinum resistant refractory, that means they have recurred within the course of treatment or within less than 6 months, or whether they are platinum sensitive. So sensitive is those that recur after 6 months. So those who are resistant to this thing, you can use other type of chemotherapy like doxorubicin, etc. And platinum sensitive, then you can combine this doxorubicin with carboplatin and give this for a period of 6 to 12 months. In the ones which are platinum resistant, you will not repeat platinum again, obviously. So we find that there are multiple relapses in ovarian CA, and we find that patients after a period of 1 to 2 years, you keep on getting relapses, and you have to further give the treatment to achieve some sort of quality of life for the patient. Targeted therapy has also been mentioned, but this has not really has not had much proof and was not commonly used. These are all under investigation and are still not proved. Surgery in relapse, and the second time, at the time of relapse, we may attempt, some surgeons may attempt surgical debulking at the time if relapse is in selected patients prior to second-line chemotherapy. Secondary cytoreductive surgery, and if you can do the cytoreductive surgery and if you can leave gross residual disease is very less than 1 centimeter, then you have more success in the further thing to improve the quality of life. Sometimes you have to do other palliative operations like colostomy for large bowel obstruction, license adhesions, gastrostomy for bowel obstruction. Minority of patients with localized recurrence may experience better survival after whole body radiation or limited radiation. This can provide rapid relief when there is massive mass causing pain, bleeding, and rectal narrowing. This may prevent the need for diverting colostomy. This can be used also in rare brain or bone metastasis. This is rarely used, but it has specific indications to be decided. Borderline tumors are a specific group of tumors where there is no invasion of the stroma, and in which you can use a different line of management. Serous or mucinous borderline tumors can be present. Mucinous can be present with pseudomyxoma peritonei. Here, surgery is the mainstay of treatment. Total abdominal hysterectomy with bilateral salpingo-oophorectomy. At times, if the person is young, then fertility sparing may also be done if the person is young, and you can follow up the case. Careful examination of the tissue block is necessary to exclude an invasive component. In borderline tumors, currently no convincing evidence is there to say that chemotherapy or radiotherapy is required. Simple observation with serial monitoring annually is required. Sometimes late relapses may occur, and if you do not follow it up, they may sometimes become into low-grade invasive cancer. If there's if there is recurrence, then also surgery is required. Then, depending on the stage at that time, you may decide upon the management, chemotherapy, etc. 6 cord stromal tumors represent about 5% of ovarian tumors. They often present in stage 1, which is excellent prognosis, granular cell tumors. They present as a solid mass, sometimes cystic features. They secrete inhibin and the Mullerian inhibiting substance. They may, in a young girl, present as precocious puberty and with abnormal menses, and in postmenopausal women with postmenopausal bleeding due to endometrial hyperplasia. Totally Leydig tumors present as virilization. Surgery is the mainstay of management and often managed conservatively. Unilateral salpingo-oophorectomy if the person is young. Those who have completed family do total abdominal hysterectomy and bilateral salpingo-oophorectomy. The staging is similar to epithelial ovarian cancer, and stage 2 onwards, adjuvant treatment is required. And in stage 1 with high-risk features such as large tumor size, high metastatic count, rupture, surface involvement, you may consider adjuvant treatment. They respond well to platinum-based chemotherapy. And so it is said that the fallopian tube is regarded as a precursor site for high-grade serous cancer carcinogenesis. Hence, it is now believed that when we are doing a hysterectomy, we have been advised to remove the fallopian tube to prevent long-term cancer occurring in the ovary. And this is what we are following. So all these cases, we find that the BRCA mutation, this leads to certain type of tumors. Hence, if you have a case with breast cancer, you have to check for the BRCA pathway. So we find in conclusion that ovarian cancer is not a single entity, but it represents tumors of epithelial, germ cell, or sex spot stromal origin. The early stage, only stage 1 is one in which we can expect cure. Otherwise, most of the stage from 2 onwards, you have to give adjuvant therapy. In locally advanced also, surgery is followed by adjuvant therapy. In very advanced cases, 3 and 4, new adjuvant followed by surgery, followed by adjuvant therapy. So indications for therapy, suboptimal resection. Even in stage 1C also onwards, you will give adjuvant therapy, and high grade, and in stage 2 and 3. Radiotherapy was used previously, but now the use is declined due to availability of better chemotherapy which are less toxic. Recurrence may occur in a locally advanced cancer, and recurrence follows a frequent relapse response with shorter intervals. So hence, this is called a chronic disease with multiple relapses. So you have to have a multi-pronged approach, integrating different types of maintenance therapy. The whole aim is to, whatever years the patient will survive, you have to aim to improve the quality of life so that the patient is comfortable. So I thank you for a patient hearing, and I would like to just mention at the end that there are no proper screening tests for carcinoma of the ovary. The CA-125 we find is very often done as a screening test, I find, in health checkup. And this leads to a lot of confusion in many of the patients, because we find the CA-125 is borderline raised. Instead of 35, it may be 60, 50. And these patients panic. And when you check the sonography is normal. So this leads to a lot of confusion. So I think that CA-125 is a screening method on a daily basis, on a regular basis, and an annual screening program should not be there, because I've had many patients who are very confused after that. And the sonography which is done in the health checkup, that may be useful. And if some ovarian enlargement is seen, then CA-125 then should be used along with the other markers. So I thank you all for a patient hearing.
Thank you so much, ma'am, for giving your precious time on the Shieldconnect page. And we are glad to have you on our platform. So let me check if we have any queries from the delegates. So, ma'am, the first question I received is that can ovarian cancer can be mistaken with ovarian cyst?
Yes, see, cyst can be a cancer. So you have to, when you see a cyst, you have to rule out whether it is possibly a cancer or not. So 1 minute, we have to rule out whether it is a cancer or not. So this, I told you, we can do by all the tests. First of all the tumor markers which you are doing, and with the sonography. So sonographic features, I mentioned that a simple cyst, it just is a cystic component, and it is got no solid areas. So if you find solid areas, you find septa, you find the cyst to be very large and abnormal blood flow, then you will suspect malignancy, and then you will do all the other tests, the tests and Doppler studies to check for malignancy. Of course, the histopathology is the final diagnosis. So all cases will be cysts first, but some of the cysts are malignant.
And the second question we received is, if we consider THA DSO, do we consider to start OCP soon after surgery? And if yes, then after how many days should we consider starting OCPs?
For whom? For total abdominal hysterectomy and bilateral salping oophorectomy?
Yes, ma'am. Yes, ma'am.
No, but if you have done it for ovarian CA or for non-ovarian CA, for what cases are you saying?
Ovarian CA.
For ovarian CAs, why will you start OC pills? No, OC pills is not indicated to start. to start. If you have done hysterectomy and bilateral salpingo-oophorectomy for ovarian CA, then and you get a diagnosis of CA, then you will be later on starting whatever chemotherapy. But if they're having hormone deficiency, then you can give only estrogen for short time. You are not supposed to give OC pills. OC pills are not indicated after the uterus is removed.
Okay, ma'am.
You don't have to give progesterone at all.
Yes, ma'am. Yes, ma'am. Thank you, ma'am, for giving all the answers to these questions. And the webinar was very crisp and detailed information from your end, ma'am. And we are glad to have you on our platform. We would like to have more sessions with you in future, ma'am.
Okay, thank you so much.
Thank you, ma'am.
Thank you. Yeah.
So we can wind up, ma'am. Thank you. Bye, ma'am.
Yeah, bye.